We are going to start the clinical section. In the clinical section, we are going to deal with 5 different categories of cases. The first category of cases are the tutorial cases. These cases are important to understand and illustrate the pathology, pathophysiology and the physiology of the vestibular system. After the tutorial cases, we will discuss the common disorders that we come across in the vestibular clinic. Then we are going to discuss some uncommon diagnoses that we are going to encounter in the vestibular clinic. Then we are going to deal with multiple diagnoses, and in the last section we are going to deal with clinical controversy case discussions, which are now not so controversial. Some were controversial, some continue to be controversial. So we will proceed with the first tutorial case. The first tutorial case is vestibular neuritis, and all the cases in this particular section are going to be drawn from Furman et al. Vestibular Disorders, a case study approach. The reason for choosing this particular book is the cases are completely worked up from the history to the follow-up. Everything has been provided for all the cases. Second thing is, this book has been around for a long time, which means a lot of people must have reviewed it, and if there are anything controversial that would have been pointed out, and coming from a book, there is not much scope for personal opinion there, so it is going to be more useful as a teaching aid. So we'll proceed with the history. A 25-year-old woman who worked as a registered nurse presented with the chief complaint of acute vertigo that began 3 days before evaluation. The patient's vertigo was associated with nausea and vomiting for several hours. Following this episode, the patient had disequilibrium, gait instability, and a complaint of poor vision for 2 days. She had no associated complaints of hearing loss or tinnitus and no fullness or stuffiness in the ear. There were no complaints of changes in strength or sensation. The patient had experienced a flu-like illness that had begun approximately 2 weeks before the onset of vertigo. At the time of evaluation, she noticed imbalance in the dark and felt disoriented, especially after large head movements. This is more of a spatial disorientation they are speaking about. She had no significant past medical history, and the family history was non-contributory. We'll go to the first question that comes out of this history. Based on the patient's history, what is the most likely diagnosis? Before the discussion of the diagnosis, let us just elaborate once again on the history. See, what are we talking about in this particular history? What is the information that has been provided in this history? Because every point is important, and this is the pattern we should be following in taking the history of our patients. First and foremost, they talk about acute vertigo. That is the primary symptom with which the patient came. They also talk about the duration of that vertigo. The next thing here is the patient's vertigo was associated with nausea and vomiting for several hours. This is the associated feature, this is the autonomic feature. Now, what other associated features are there other than the vertigo? The patient had disequilibrium, instability of gait, and a complaint of poor vision for the past 2 days. This particular complaint of poor vision is important to interpret here. Now we know the diagnosis, we are proceeding with the 5 tutorial cases, knowing the diagnosis beforehand. So it is instructive to know how some patients actually complain of their visual problems that are associated with nystagmus. Some patients do complain of poor vision rather than of that what we consider as an external vertigo where the things are shaky. So some people some people explain the shakiness, some people just tell that the vision is not that clear. This is not the same as a blurring of vision or the scotoma or the blackouts that happens. So we can actually elaborate and ask, what do they mean by the poor vision? Is it actually a blackout? Is it actually a total blurring of vision? What exactly is happening to them? To know what is it a scotoma that is happening? To know the further detail. She had no associated complaints of hearing loss or tinnitus and no fullness or stuffiness of the ear. So what we are now proceeding to is We know that on the vestibular part there seems to be some problem. What is happening on the cochlear side of the inner ear? If at all it is arising from the inner ear or the inner ear connections, what is happening on the other side of the inner ear is what we are asking by asking hearing loss, tinnitus, no fullness or stuffiness in the ear. There were no complaints of changes in strength or sensation. These are neurological signs. The patient had experienced a flu-like illness that had begun approximately 2 weeks before the onset of the vertigo. This is like what could have led to the present condition. Maybe it is a viral illness that is actually led to the present condition. At the time of evaluation, she noticed imbalance in the dark and felt disoriented, especially after large head movements. So, the imbalance was there and she noticed the imbalance to be little more in the dark, and this is typical of vestibular losses. Okay, vestibular, when the vision is removed, they feel even more imbalance. She had no significant past medical history and the family history was non-contributory. So based on the patient's history, what is the most likely diagnosis at this particular point of time? So we elaborated on some of the points why they were actually asked. So based on that, we can come to what is the likely diagnosis and what are the other candidates for diagnosis and whether they are likely or not likely. So in a person presenting with acute vertigo, we need to have certain candidate diagnosis in our mind. So the patient's history is consistent with an acute vestibular syndrome. Okay, and what are the candidate diagnosis for the acute vestibular syndromes? Okay. So this person had acute vestibular syndrome characterized by vertigo, nausea, vomiting, blurred vision and disequilibrium. The absence of auditory symptoms and prior flu-like illness suggests the possibility of vestibular neuritis. There is no auditory symptom and there is the presence of flu-like illness. Most likely it is vestibular neuritis. But is it only that? What other competing candidates are there for the diagnosis? Other less likely conditions include endolymphatic hydrops, migraine-related dizziness. Endolymphatic hydrops or Meniere's disease and migraine-related dizziness need a certain number of episodes for a definitive diagnosis. However, this particular episode could represent the first episode of Meniere's, could represent the first episode of migraine-related dizziness, or it can represent a severe cerebrovascular accident or a demyelinating disorder. The absence of other otological symptoms argue against endolymphatic hydrops. Okay, the point that is against Meniere's disease is that there is no other otological symptom, it is only vertigo, there is no tinnitus, fullness, oral fullness or hearing loss. Migraine related dizziness or CVA are unlikely at this stage, but we have to build up on why they are unlikely. Okay, as we take additional history or are we for CVA more examination, and when it comes to migraine related dizziness, additional history. At least in the history that has been provided, there is no previous similar episodes or previous history of migraine related features. The absence of non-vestibular neurologic symptoms, and the absence of previous neurological deficits. So a neurologic symptom not related to the present neurologic symptom, that is not there, and no other neurologic deficit before. Two important points. A neurologic symptom not related to the present symptom, that is non-vestibular neurologic symptom, and the absence of previous deficits make a demyelinating lesion unlikely. Now the physical examination. The physical examination that has been provided is neurologic examination revealed a left beating horizontal torsional nystagmus on leftward gaze with the upper poles of the eye beating to the left. The patient's nystagmus increased during gaze towards the left and decreased during gaze towards the right. So what has been described now? The direction of the nystagmus has been described. It is left beating, horizontal and torsional nystagmus. Next thing that has been described is, it is the change in the nystagmus behavior with the change in the gaze has been described. Nystagmus increased during gaze towards the left and decreased during gaze towards the right. Only the intensity changed. The direction did not change. The remainder of the cranial nerve examination was normal. Strength, sensation and coordination were normal. The patient had a negative Romberg's test. Gait was wide-based and the patient could not tandem walk. The otologic examination itself was normal. The neurotological examination was abnormal. So what were the abnormal neurotological findings? Behind infrared goggles, the patient nystagmus increased in intensity. It was now observed even in the primary position. In the first sentence they said it was only on the left gaze with the upper poles beating to the left and the left beating horizontal nystagmus and torsional nystagmus upper pole beating to the left. This was what was observed. Though they do make a statement that decreased in intensity towards the right, it looks like absence of nystagmus on right gaze is what they are talking about, decrease in intensity on the right, because the further discussion is on those lines. The patient had a negative Romberg test, gaze was wide-based and the patient could not tandem walk. The otologic examination was normal. Neurotological examination was abnormal. That is, behind infrared goggles, patient's nystagmus increased in intensity. It was now observed in the primary position. And both the frequency and amplitude of nystagmus were higher. So, in the beginning, only on the left side there was a nystagmus. Now, not just on the left gaze, even in the primary gaze, on the center gaze also, the person was getting a nystagmus. But the direction remained same, but the frequency and amplitude of nystagmus were higher. The head thrust test or the head impulse test was abnormal, with refixation saccades noted following head rotation from left to right. Head rotation from left to right means right-sided head impulse was impaired. Left head impulse was normal. The patient was unable to stand on a compliant foam surface with her eyes closed without losing balance. So the point to note here is negative Romberg's test. Negative Romberg test means it was done on firm surface, eyes open and eyes closed, the patient was stable. Whereas on a compliant foam surface, the patient could not stand without losing her balance, which goes more in favor of it with her eyes closed, goes in favor. This is the specific test for vestibular contribution to the sensory integration of balance. The vestibular contribution to the integration of balance is tested with eyes closed and on the foam surface. Past pointing was present with arm deviation to the right. It's a very important point what we're talking about here, past pointing. Past pointing is sometimes considered as a cerebellar sign, but why do we see that? In the vestibular neuritis is what we are going to see further. Past pointing was present with arm deviation towards the right. So past pointing was seen towards the right, not towards the left. This person has a left beating nystagmus and the past pointing was towards the right. So the nystagmus is something like this. This belongs to another patient. There is a horizontal and a torsional component. With fixation, the horizontal suppresses a little more. Therefore, it looks more like a pure torsional, but there is a horizontal component to this. This has been documented with video nystagmography also, the presence of horizontal nystagmus. So what happens on removal of fixation to that same nystagmus is the intensity of the nystagmus increases. The difference between the first and the second video is the first video the pupils were small, the second video pupils are big, telling us that the fixation has been removed. The head thrust test, this again is of a different patient. Just to illustrate it, I am bringing it here. Keep looking at the camera. In a lot of patients, when we are doing the head impulse test, especially when the head impulse is impaired, even on one side, they start developing a behavioral response that is blinking. That is to prevent the visual blurring with rapid head movements. They just close the eyes. That is what is observed in a lot of patients, and therefore interpretation becomes a little difficult. When the person moved the head to the left, the eyes remain fixed on the camera. The other way of finding whether it was remain fixed or not is when the head stopped the movement, did the eyes move? If the eyes are moved after the head movement stopped, then it is likely that there has been a refixation saccade. See, as the head stops, by then the eye movement is also stopped. Okay, after the head has stopped, there is no eye movement. After the head movement has stopped, there is no eye movement on that side. You will see that more on the other side, which is the impaired side, that is the right side. Sometimes they blink. So under the blink, the eye started moving. But then towards the end, we get one impulse where the person does not move, does not blink, and at that time we can see. But what we are exactly noticing here is, once the head movement stops, after the head movement on the right stops, then is where the eye starts moving. Okay, you can make out that. Whereas on the left side, that did not happen. After the head movement stopped, you did not see the eye movement. And then later on, you are seeing some nystagmus also. So under the blinked eye, you could notice something moving, but then we get one more impulse a little later, which demonstrates the movement of the eye after the head movement has actually stopped. You can see that after the head movement has stopped, then is where the refixation saccade happens. That means on the right side, the head impulse is impaired. Following that, the nystagmus starts showing up. That's another contribution, another feature of the acute vestibular syndrome. On the left side, okay, you saw that he was still blinking, but there was no movement of the eye. And you will still see one without the blink. You can see some nystagmus, that is in slow motion. You can see that after the head stopped, there is no eye movement. There is absolutely no eye movement after the head has stopped. Whereas on the right side now, please notice what happens on the right side. Now without blink, it is going to happen. The head starts to move now. And head movement stopped. After that, the eye has moved. So that means that there has been the Romberg test, again very illustrative. We asked the person to close the eyes. Even on closure of the eyes, as long as they are on the firm surface, they can still stand. Okay, vestibular neuritis patients can stand. This is a tutorial case. We are knowing the diagnosis. We are proceeding to know what all the manifestations that can be seen in this particular patient. With the eyes closed, they can stand. So what is the pathophysiology of the patient's symptoms and signs? What does it actually teach us about the vestibular system? The patient is suffering from an acute peripheral vestibular syndrome, almost certainly caused by an acute, profound imbalance between the afferent activity from the right and left labyrinths. There is an imbalance between the right and the left. That is what that nystagmus suggests. Because a large difference in neural activity normally occurs only during large head movements, the central nervous system interprets an acute loss of vestibular activity as on one side as the head rotating briskly towards the intact ear. We'll illustrate this with a video. Patients thus experience vertigo. Vegetative symptoms of nausea, vomiting, diaphoresis result from activity in the pathways from the vestibular system to the autonomic nervous system. So these vegetative symptoms are actually autonomic are because of the projections to the autonomic nervous system. So what is this imbalance of afferent activity between the right and left? What is it? What do we mean when it happens only during large head movements? So let us see a video. So this is me turning towards my left. When I turn to the left, you can notice that there is a nystagmus that beats to the left. You can see that again. When I turn to the left, you can notice that there is a nystagmus that is beating to the left. So that was a large head movement. A large head movement to the left produces a left beating nystagmus. Why does this happen? A person who is not moving from the right labyrinth and the left labyrinth, the neural activity is the same. Between the right and left labyrinth, the neural activity is the same. The brainstem interprets the difference in the activity between the right and left labyrinth to tell whether there has been a movement. If the net difference is there, if the left side labyrinth is producing more signals, it is read as a leftward head rotation. If the right labyrinth is producing more signals, it is read as a rightward head rotation. When in the video I turned to the left side, the left ear there was a stimulation and the right one was inhibited. Okay. So there is a net difference with the left side signals much more than the right ear's signals. And that is what happens during left head rotations. And the left side, when the signals become more, the eyes move slowly to the right and a beat to the left. So left direction, leftward rotation causes left beating nystagmus. In a person in whom the right ear is destroyed, that is equivalent to this one as far as the difference in input is concerned. So this is continuing to output at a resting rate, but compared to the side which is not working, there is a net difference. Real head rotation is because of increased activity here, reduced activity here. Perceived head rotation is because of intact activity here, absent activity here, still causing a difference. So difference means there is a head rotation. Here the difference is caused by a real head rotation. Here there is a difference, therefore there is a perception of head rotation. Perception of rotation in the absence of real rotation is what is called as a vertigo. So what is the significance of the patient's nystagmus being horizontal and torsional? When you look at the ocular motor effects of the semicircular canal stimulation, we've been going through what all the different kinds of movements that are produced by each semicircular canal. The horizontal canal produces a horizontal movement of the eyes, both right and left eye. Right horizontal canal moves both the right eye and the left eye to the left. Left horizontal canal moves both the right eye and the left eye to the right. These are the slow phase. So posterior canals pull the eye downwards, anterior canals or superior canals pull the eye upwards. Torsionally right-sided vertical canals move the upper poles to the left. Left-sided canals move the upper pole to the right. In a normal individual, when all the canals are working well, every arrow has an opposing arrow. So the horizontal arrow to the left has an opposing arrow here. This torsion has opposing torsion to the other side. The downward has an opposing upward. So every arrow is cancelled by the other arrow, and that is what happens. That is what leads to not being any nystagmus in a normal individual. Whereas in a person in whom one labyrinth is destroyed, the patient we are discussing is right vestibular neuritis, whereas here we are talking about the diagram here that I have chosen is about left-sided complete loss of all the three semicircular canal functions. So when you see this, what happens is these arrows which are shown in red no longer contribute to cancellation. So therefore what you get is what is net here. So what is net left on the right side is there is a slow phase movement in the horizontal plane. There is a torsional movement which gets added up, but there is no vertical movement because the vertical movement of the posterior canal and anterior canal are in opposing direction. They cancel against one another, and therefore you see this horizontal torsional, huge torsional component, and there is a horizontal component. So this is what you get in complete loss of vestibular. This is slow phase, and the fast phase will be to the opposite side, horizontal torsional to the opposite side in case of left labyrinth. In our patient, it is the right side is lost, therefore you get slow phase in the opposite direction, but the nystagmus will be to the left. Horizontal left beating nystagmus and upper pole beating to the left. What are the ocular motor effects of failure of only the superior vestibular nerve? If only the superior vestibular nerve is gone, then what would happen is the horizontal is not opposed, but the vertical also is not completely opposed because one vertical is opposed by the other vertical, but one vertical remains which is not opposed of the left-sided posterior canal here in case of left superior vestibular neuritis. Therefore, that leads to a vertical component, which means there is a slow drift of the eye downwards, nystagmus will have a upbeating nystagmus, upbeating component to the nystagmus, not pure upbeating component to their horizontal torsional nystagmus. So, absence of an upbeating component means that the entire labyrinth is gone. That is, both superior and inferior vestibular divisions are affected by the disease process, or the entire labyrinth is affected by the disease process. If there is a vertical component, that means that there is a partial affliction. So the answer is, the patient nystagmus is caused by imbalance in the afferent activity from the left and right labyrinths, and is probably a result of imbalanced semicircular canal activity rather than imbalance of otolith activity. Because of the orientation of the three semicircular canal pairs, the affected afferent activity from the intact ear, if unopposed by activity in the affected ear, combines to produce a slow component of nystagmus whose direction has specific characteristics, and those specific characteristics we saw in the diagrams before. Activity from the unopposed left horizontal canal drives the eyes horizontally towards the right. The combined activity of the two left vertical semicircular canals, that is left superior and left posterior semicircular canals, causes a slow torsional movement of the eyes with the upper pole moving to the right. No vertical component is produced because left superior semicircular canal tends to drive the eyes up, left posterior semicircular canal tends to drive the eyes down, thereby cancelling the vertical influences. So the torsional influences are getting added up, the vertical influences are getting cancelled. Thus, the predominantly horizontal torsional nystagmus suggests a net effect of three unopposed semicircular canals of the patient's left ear combining to produce a nystagmus whose slow component has a horizontal direction towards the lesioned ear and whose quick component, the nystagmus is named after the quick component, beats horizontally towards the intact ear. So whenever you see a left beating nystagmus, left ear is intact, or if it is physiologically, the person may be rotating to the left side, or the left ear's activity may be increased, as in warm caloric stimulation of the left side. So this is the meaning of the left beating nystagmus. Or the right has become weak. So right has become weak and the left is intact, or right has been rendered weak by cold caloric stimulation, or there is rotation, real rotation to the left, or the left activity has increased by warm caloric stimulation of the left side. These are the meaning of left beating nystagmus. Why did the patient's nystagmus increase during gaze towards the left and decrease during gaze towards the right? We discussed Alexander's law in the gaze related section of the video nystagmography. The alterations in the patient nystagmus as a function of eye position in the orbit. Eye position in the orbit means whether the person is looking to the right, looking to the left, looking up to the left, to the center or to the left, is what is going to change the nystagmus behavior. Okay, the alterations in the patient nystagmus as a function of eye position in the orbit are typical of most types of nystagmus, wherein the intensity of the nystagmus, including its frequency and amplitude, increases when the patient looks in the direction of quick component. This phenomenon, whereby the magnitude of the nystagmus changes as a function of eye position, is known as Alexander's law. The physiologic basis for Alexander's law may relate to an alteration in the neural integrator leading to a combined effect of vestibular nystagmus and gaze-evoked nystagmus. We did deal with gaze-evoked nystagmus in the VNG section. So any acute vestibular insult leads to a dysfunction of the neural integrator. A dysfunction of the neural integrator leads to the development of a gaze-evoked nystagmus. Now, how does the gaze-evoked nystagmus interact with the vestibular nystagmus? Is what is going to explain the behavior that we see in Alexander's law. What is the behavior that we see in Alexander's law? If the person has a left beating nystagmus, on left gaze, the intensity becomes more. So why is this so? What happens to the gaze-evoked nystagmus on left gaze? On the left gaze, we get a left beating nystagmus, which means slow component is to the right. Slow component is to the center. Gaze-evoked nystagmus is because the eyes are drifting to the center. So left gaze, left beating nystagmus means slow component is towards the center or to the right. In this particular individual on left gaze, the slow component because of gaze evoked is to the right. The vestibular nystagmus is left beating means vestibular slow phase is also to the right. So the vestibular rightward slow phase, the gaze evoked nystagmus rightward slow phase, both of them get added together. The intensity of the nystagmus is high. Whereas when the person looks to the right side, the gaze evoked nystagmus is to the right. We know any acute vestibular insult can lead to disturbance of neural integrator that leads to gaze evoked nystagmus. So this person, because as a result of the acute vestibular insult related neural integrator deficiency, is developing a gaze evoked nystagmus. On the right beating, on the left beating. But now on the right beating gaze evoked nystagmus, how does it interact with the vestibular nystagmus, and what is the final nystagmus that we see? What is the final nystagmus that we see is what we are going to see. So if on the right, the gaze evoked nystagmus because of neural integrator deficit produces a right beating nystagmus, that is because gaze evoked simply means that the eyes are drifting to the center. On the right gaze, drifting to the center in the slow phase. Drifting to the center in the slow phase means slow phase to the left. Slow phase to the left. Whereas the vestibular imbalance in this same particular individual, slow phase is to the right. So the slow phase of gaze evoked nystagmus and the slow phase of vestibular nystagmus cancel against one another, and therefore the net resulting nystagmus that we see is going to be low, is going to be of a low intensity. This is the explanation of Alexander's law. So when a patient with left beating nystagmus looks to the left, both the gaze evoked nystagmus and the vestibular imbalance cause rightward slow movement, thereby increasing the magnitude of nystagmus. However, on right gaze, the vestibular imbalance and the gaze evoked nystagmus oppose one another, thereby decreasing the intensity of nystagmus. Thereby decreasing the intensity of nystagmus. Now this brings us to a very valid and very important point. We have been told that direction changing nystagmus is a central condition. Now here there is an interaction of the gaze evoked nystagmus and the vestibular imbalance. And the vestibular, as long as the vestibular imbalance outweighs the gaze evoked nystagmus, outweighs the gaze evoked nystagmus, now the direction of the vestibular nystagmus is what is going to be seen. So what is going to happen here is the person has a right vestibular neuritis. Right vestibular neuritis causes left beating nystagmus. Very clear. On the left gaze it is left beating nystagmus. On the center gaze it is going to be left beating nystagmus. On the right gaze it is the interaction between the gaze evoked nystagmus and the vestibular nystagmus. A stage is going to be reached when the vestibular imbalance becomes less than the gaze evoked nystagmus, in which case you may start seeing a different direction. On the right gaze you will still see a right beating nystagmus of a lower intensity. So this kind of a phenomenon can be seen in individuals of pure vestibular neuritis also. So low intensity nystagmus on right gaze to the right. Okay, especially in the face of no nystagmus in the center gaze, we have to interpret with caution. It need not mean, just because of direction changing, need not mean that it is a central condition. The Alexander's nystagmus can be graded and plotted in different ways. Here the authors have provided a particular picture of left on this side and up to the left and right, as if the person who is writing them, his left and his right. This may not be the best convention. We follow a different convention, as if the person is facing us. That is the convention that we follow, so that is better. But this diagram is included to illustrate one important feature of how to actually grade and note their nystagmus. So when you see here, the length of the arrow tells the intensity of the nystagmus, or the thickness of the arrow can be used to describe the intensity of the nystagmus. Direction of the arrow to tell which direction the nystagmus is beating. And in different gaze positions is what the 9 quadrants there tell. So the in the center gaze, in the first picture and on the right gaze there is no nystagmus, only on the left gaze there is a nystagmus, that is seen. So same happens in so 9 cardinal positions, and in the positions what is happening to the nystagmus is what is shown, and here only the horizontal component has been illustrated. In the second degree, first degree is only one gaze, in second degree both in the primary gaze and on the gaze in the gaze in which direction the nystagmus is beating. Like if the person is beating to the left beating nystagmus, left gaze will be more. If the person has a left beating nystagmus, and if you see a nystagmus on the left, in the center and also on the right gaze, then it is called as a grade 3 nystagmus or third degree nystagmus. So first degree, second degree and third degree. First degree in only one position, second degree in 2 gaze positions, and third degree in all the 3 gaze positions. So vestibular nystagmus, which is unidirectional, is sometimes graded in severity based upon its presence in different horizontal gaze positions. Specifically, Alexander's system, which was originally applied to patients observed during visual fixation, includes first degree, second degree and third degree vestibular nystagmus. In third degree nystagmus, the nystagmus is unidirectional and can be observed regardless of the horizontal gaze position, means it is present in all the positions. But the intensity of the nystagmus is maximal with the gaze in the direction of quick component of nystagmus. That means left beating nystagmus will be maximal on the left gaze and is minimal but still observable when the horizontal gaze is directed away from the quick component. In second degree nystagmus, the nystagmus is observed only when the patient gazes straight ahead or in the direction of the quick component. In first degree nystagmus, the nystagmus can be observed only with the gaze in the direction of the quick component. This patient had first degree vestibular nystagmus since left beating nystagmus was observed only with left gaze. This is only with left gaze with fixation because Alexander's system was described observing patients with fixation. So that is why this particular person in the Alexander system will be considered as having a first degree nystagmus because we are disregarding what we saw once the fixation was removed, because Alexander's system was described or was originally applied to patients who are observed during visual fixation only. Question number 5. Why is the patient's nystagmus increased in magnitude when she is wearing infrared goggles or when the fixation was removed? Why did the nystagmus increase? Vestibular nystagmus, whether it is physiological or pathological, can be significantly inhibited by visual fixation when vision and visual fixation and visual tracking mechanisms are intact. Two things here. The vestibular nystagmus, both pathological and physiological. Pathological as happens in this particular patient of vestibular neuritis, physiological as happens in caloric test, as happens with chair rotation test, VOR suppression test, all these things we are doing. Okay. So we have vestibular nystagmus. This vestibular nystagmus is inhibited with vision. The mechanisms are visual fixation mechanism and visual tracking mechanism. Visual fixation and visual tracking or smooth pursuit mechanisms share the pathway to a great extent. Both fixation and pursuit share the pathways to a great extent, and they interact with vestibular nystagmus to suppress the vestibular nystagmus. Infrared or video frenzel goggles allow the patient's eyes to be observed while they significantly reduce visual fixation, which means the contribution of visual fixation system, the contribution of the smooth pursuit system, okay, is reduced. An increase in the patient nystagmus on wearing infrared or frenzel goggles supports the idea that the patient nystagmus originates from a vestibular imbalance, usually peripheral. The video which we saw illustrates just now we saw the video in which we saw with fixation and without fixation, illustrates the influence of loss of visual fixation on the severity of the vestibular nystagmus. Note that in its mildest form, the vestibular nystagmus may be absent with visual fixation, observed only with loss of visual fixation, and also with lateral gaze to the right or left depending on the direction of the nystagmus. So, it may be that if it is of a very low intensity, you not just have to remove the fixation, in addition to removing the fixation, you may have to ask the patient to look to right gaze or to left gaze to demonstrate the presence of that particular nystagmus. In clinical practice, a horizontal torsional nystagmus that increases in magnitude with loss of fixation is called a vestibular nystagmus. So, if we tell I saw a vestibular nystagmus in this patient, What it means is I saw horizontal torsional nystagmus, not pure horizontal, not pure torsional, not pure vertical. It is a horizontal torsional nystagmus, and that horizontal torsional nystagmus increased in magnitude with loss of fixation. So when you use the term vestibular nystagmus, you are talking about a horizontal torsional nystagmus and that nystagmus having increased in magnitude when the fixation was removed. The investigations. Video nystagmography ocular motor testing was normal. Testing confirmed the presence of a left beating spontaneous vestibular nystagmus on left gaze that increased with loss of fixation. Caloric testing revealed absent responses in the right ear, including absent responses to ice water irrigation. WEMPs were absent on the right. Audiometric testing was normal. An MRI scan of the brain with and without contrast with attention to IACs, internal auditory canals, and the brainstem was normal. The thing to note here is, number one, the vestibular nystagmus, the spontaneous, left beating spontaneous vestibular nystagmus. We know what is the meaning of vestibular nystagmus now. Horizontal torsional nystagmus, which becomes more on removal of fixation. But the more important point here is the caloric testing revealed absent responses in the right ear. Whenever you suspect a vestibular neuritis, it is very important to do a caloric test. It is very important to do a caloric test, and at least on that one particular ear on which you are suspecting, because one is, if the diagnosis is vestibular neuritis, the patient is not going to have the caloric testing related illness. The nausea, the vomiting, these kind of things that happen because of the caloric testing will not be seen in this particular patient because that ear is not responsive. And it also confirms that that inner ear is non-responsive. If you are clinically suspecting a vestibular neuritis on the right ear and the patient starts showing a response on the right caloric, then you need to revisit the diagnosis. That is why caloric testing is very important in every patient of suspected vestibular neuritis. How do results of laboratory testing influence the diagnostic considerations for this case? Influence means, does it change? Does it strengthen? What is what we are trying to do? The most significant finding on vestibular laboratory testing are the reduced vestibular response in right ear on caloric testing and the absent right WEMP. Although unilateral vestibular loss was suspected from clinical evaluation, the laboratory testing provides objective evidence of a severe loss of sensitivity in the right vestibular system that involves both superior and inferior branches of the vestibular portion of the 8th cranial nerve. Both branches are affected. The normal audiometric test suggests that the patient is suffering from a pure vestibular syndrome, not an inner ear syndrome. It is not a labyrinthine syndrome, it is a vestibular syndrome, such as vestibular neuritis, as opposed to a more generalized labyrinthitis, which is commonly associated with a high frequency hearing loss, or from endolymphatic eye drops, which is often associated with a low tone sensorineural hearing loss. The normal MRI rules out a structural lesion. Now, what is the diagnosis or differential diagnosis? As noted, this patient is almost certainly suffering from vestibular neuritis. Other names for this condition include vestibular neurolabyrinthitis, vestibular labyrinthitis, vestibular neuronitis, and acute vestibulopathy of uncertain etiology. These are all interchangeable terms. These terms are used interchangeably. It should be realized that a peripheral vestibular lesion could actually be affecting the hair cells, the 8th nerve afferents, or the 8th nerve root entry zone. From the vestibular signs and symptoms alone, a distinction cannot be made among these three localizations. Post-mortem temporal bone histopathology suggests that Scarpa's ganglion is affected primarily in vestibular neuritis. This is other patient studies, not of the patient in question. The picture illustrates atrophy of the vestibular nerve thought to be the result of a viral vestibular neuritis. I will show you that picture. The pathologic data suggests that the vestibular neuritis has a predilection for the superior vestibular nerve. However, there are recent WEMP-based studies which tell up to 40% of patients may have involvement of the inferior vestibular nerve also. In this case, in this particular patient, abnormal WEMPs on the right as well as abnormal caloric responses on the right suggest the involvement of both superior and inferior branches of the vestibular nerve. The patient's MRI supports a diagnosis of vestibular neuritis by ruling out a structural lesion. The patient was given a diagnosis of vestibular neuritis. The picture that we talk about the atrophy is this. On the top, you can see a normal lateral canal, all the the nerve to the lateral canal quite intact, okay, with all nuclei we can see. Whereas here, when you see here, it's all atrophied, okay. So this is post-mortem histopathology of a particular patient who had vestibular neuritis in the ante-mortem period. So treatment or management. A short 10 to 14 days course of corticosteroids, for example, prednisolone 1 milligram per kg per day, decreases the duration of vestibular symptoms, may also reduce the chance of future recurrent episodes of acute vertigo, and increases the likelihood of a return of vestibular function. Why should we give corticosteroids? The reason for giving corticosteroids are threefold. It definitely reduces the duration of the symptoms. It reduces the chance of future recurrences of the episodes of vertigo. Third one is increases the likelihood of a return of vestibular function, which means it is not that the nerve is dead and it has to remain dead. No, the chance of that nerve returning function is also increased by giving the corticosteroids. It is common practice not to prescribe corticosteroids if more than 1 month has lapsed since symptom onset. At that point of time, they don't have a benefit. Antiviral agents such as acyclovir may be considered since viral reactivation is thought to be involved in the pathogenesis of condition, may be considered, but there is no data to conclusively support its use in this setting, and a controlled study has shown no value for antiviral agents. This patient was treated with a 2-week course of corticosteroids. Vestibular suppressants and anti-nausea agents were also prescribed on an as-needed basis for symptomatic relief. The patient was referred for a course of vestibular rehabilitation. The follow-up of this patient, the patient was seen in follow-up 1 month after the initial presentation. At that time, she was very much improved and experienced symptoms only during rapid head movement, which caused transitory dizziness and lightheadedness, and during walking in dimly lit or dark environment. The patient also noted some difficulty with driving, especially immediately after rapid head movement just before changing lanes. Physical examination at 1 month follow-up visit revealed no nystagmus with visual fixation. However, behind infrared goggles, a low amplitude left beating horizontal torsional nystagmus was observed with the left gaze. This is what we spoke about before. In addition to removing the fixation, you also need to make the person look in one direction to unmanifest or to manifest a certain vestibular asymmetry, okay, when it is of very low intensity. The head thrust was unchanged, that is still abnormal with rightward head movement. The patient's gait had a normal base, but there was some difficulty only during tandem walking. The patient was able to stand on a compliant foam pad even with her eyes closed with minimal difficulty. The patient was advised to continue vestibular rehabilitation. Now, by what process did this patient's symptoms and signs almost completely resolve? We see the nystagmus has definitely reduced. The symptoms have reduced except for driving, very fast head movements, except those symptoms, most of the symptoms are gone. How did this happen? Despite the fact that the patient's vestibular loss in the right ear almost certainly persists, you know it is persisting because on the head thrust test, the person continues to have the problem. Vestibular compensation, a process that involves rebalancing of the activity in the central vestibular structures, has occurred. Through this mechanism, the vestibulo-ocular, vestibulospinal, perceptual and autonomic symptoms and signs improve substantially, although some symptoms, as noted above in this patient, are likely to persist. Vestibular compensation occurs automatically in individuals with a normal central nervous system, normal vision and proprioception, and adequate physical activity. The important things is central nervous system normal, vision normal, proprioception normal, and activity normal. This patient's recovery is typical even for individuals who have suffered complete unilateral peripheral vestibular loss. The process of vestibular compensation is thought to involve both the brainstem and the cerebellar structures, so that resting activity in the left and right vestibular nuclei become more or less balanced despite unilaterally reduced or absent vestibular nerve activity. The point here is the resting activity becomes balanced. This person continues to have some symptoms during fast head movement because that activity need not be compensated as well as the resting or baseline activity. Early intervention with vestibular rehabilitation may have facilitated her rapid improvement. The summary is a 25-year-old woman presented with acute onset of vestibular syndrome indicative of an acute unilateral peripheral vestibular loss. The patient's history suggested a viral or post-viral affliction of the vestibular labyrinth or nerve. Examination revealed horizontal torsional spontaneous vestibular nystagmus, a positive head thrust test to the right, past pointing, and an inability to stand on a compliant foam surface with the eyes closed. This past pointing that we see here in one direction is actually a vestibular imbalance sign. Laboratory testing revealed a right reduced vestibular response on both caloric and WEMP testing. An MRI was normal. The patient was treated with a 2-week course of corticosteroids and vestibular rehabilitation. Vestibular suppressant agents and anti-nausea agents were used only on an as-needed basis. Through the process of vestibular compensation, the patient's symptoms decreased dramatically. At the 1-month follow-up evaluation, nystagmus was present only with loss of visual fixation, that too on only one gaze, and she could tandem walk and stand on a compliant surface with little difficulty. The teaching points that this case teaches us is an acute unilateral vestibular syndrome is characterized by vertigo, nausea, vomiting, blurred vision, and disequilibrium. These symptoms and signs result from an imbalance between the afferent activity from the left and the right labyrinths. Again, to note that point of blurred vision, not all people actually complain of a shakiness of the vision. They actually simply tell blurred vision. Okay. The central nervous system interprets this imbalance as a brisk, continuous head rotation towards the intact ear. Vegetative symptoms of nausea, vomiting, and diaphoresis are characterized by activity in the pathways from the vestibular system to the autonomic system. The direction of acute vestibular nystagmus is typically horizontal torsional. This direction of nystagmus results primarily from unopposed horizontal semicircular canal afferent activity from intact sites that produces a horizontal direction of nystagmus. The afferent activity from the two intact vertical semicircular canals sum with one another such that torsionally the upper poles of the eye torts or rolls towards the lesion ear. The vertical eye movement drives off the vertical semicircular canals cancel against one another. Just to reiterate, the torsional drift adds up, the vertical drifts cancel. The three unopposed semicircular canals of the intact ear thus combine to produce a predominantly horizontal torsional nystagmus whose slow component is toward the lesioned ear and whose quick component, for which the nystagmus direction is named, beats towards the intact ear. The Alexander's law, wherein the intensity of nystagmus, including its frequency and amplitude, increases when a patient looks in the direction of quick component, is typical of most types of nystagmus. The physiologic basis for Alexander's law may be related to changes in the neural integrator leading to gaze-evoked nystagmus. Visual fixation inhibits vestibular nystagmus when vision and visual fixation / visual tracking mechanisms are intact. Lack of fixation suppression of nystagmus means the pursuit pathway or the fixation mechanism is also destroyed. Infrared or Frenzel goggles allow the patient's eye to be observed while visual fixation is significantly reduced. Thus, an increase in the patient nystagmus when wearing infrared or Frenzel glasses supports the idea that the patient nystagmus originates from a vestibular imbalance. In clinical parlance, a horizontal torsional nystagmus that increases in magnitude with lots of visual fixation is called vestibular nystagmus. Vestibular compensation rebalances the neural activity in central vestibular structures. This process causes a reduction of the symptoms and signs of an acute vestibular syndrome. Through compensation, vestibulo-ocular, vestibulospinal, perceptual and autonomic symptoms and signs of the acute vestibular syndrome largely resolve. Vestibular compensation occurs automatically in individuals with a normal central nervous system, normal vision and proprioception, and adequate physical activity. Bed rest is counterproductive. We need to actively encourage patients to start moving around, and that has to be emphasized again and again. The process of vestibular compensation is thought to involve brainstem and cerebellar structure so that resting activity in the left and right vestibular nuclei become more or less balanced despite unilaterally reduced or absent vestibular nerve activity. Vestibular neuritis is the diagnostic designation given to an acute vestibular syndrome without obvious cause that occurs without auditory or neurologic signs or symptoms. The underlying pathogenesis is thought to involve viral activation within the vestibular nerve. Other conditions that can cause an acute vestibular syndrome include endolymphatic eye drops, demyelinating disorder, infarction involving the labyrinth and or the brainstem or cerebellum. The treatment of vestibular neuritis with a short course of corticosteroids is actually beneficial because it may decrease the duration of vestibular symptoms, improves the long-term recovery. With that, we complete the discussion of the first tutorial case.